Hello there. My name is Scott Sexton. I'm a pharmacist and I'm an assistant professor at the Ferris State University College of Pharmacy. Today I'll be presenting to you on the implementation of a standardized approach to increase naloxone access in the community pharmacy. So to begin, I just want to say that I have no disclosures. And we have two simple objectives today. The first and foremost is to define a standardized approach to increase naloxone access in a community pharmacy. Second is to integrate useful training tools that have shown success in a pilot pharmacy in North Carolina. So before we begin, I'd like to give just a little bit of background. Prescription opioid overdose is a hot topic. Now, I'm sure everyone listening right now is aware of that, but I do want to provide just a couple of statistics. The rate of drug overdose deaths has actually increased by more than 3 times from 1999 to 2017. There have been 47,600 opioid overdose deaths in the United States just in the year of 2017. And that actually accounted for 67.8% of all of the drug overdose deaths. So more than 2/3 of drug overdose deaths were caused by opioids. And North Carolina is listed on a list of states that has had a statistically significant increase in overdose deaths from 2016 to 2017. So this problem is not going away. So certainly there has been some regulatory response that has been triggered by this opioid epidemic. That's been on the state level, on the federal level. You've heard about it in the news. I really want to focus in on the CDC guideline for prescribing opioids for chronic pain that came out in 2016. More specifically, even as a part of that guideline, I want to focus on some of the risk factors that they identified for patients that are at risk of an opioid overdose. So some of those notable risk factors that they identified were morphine milligram equivalents, or an MME, of 50 per day or greater. So what that means is, even if they're not taking morphine, but they're taking a different opioid, it would be equivalent to taking 50 or more milligrams of morphine per day. So that's one risk factor. The next one I want to focus on is the concurrent use of a benzodiazepine with an opioid medication. And lastly, a history of overdose or substance use disorder. Now, surely there are additional risk factors for opioid overdose. Things like chronic hepatitis or cirrhosis, bipolar disorder, schizophrenia, chronic lung disease like COPD, significant CKD, recent hospitalization, and many others. But for the purposes of this presentation, I'd like to key in on those 3 bolded ones in the second block there, because if we focus on every single opioid risk factor, it would quite simply just be too cumbersome for implementation. So I've talked about naloxone, and at its core, naloxone is simply an opioid antagonist. And what that means is that it reverses the effects of opioids. If there's no opioid present in the body, then naloxone has no effect. I've also spoken about regulatory changes, and as part of those regulatory changes, naloxone's access has become expanded nationwide, and that's no different than here in North Carolina, where we now have a statewide standing order in place. So what is a statewide standing order? Well, basically what it says is that we are able to dispense naloxone out of our community pharmacies, and that is including both the intranasal and the intramuscular dosage forms. And who is that available to? Well, quite frankly, any willing participant. And if you read in between the fine lines, that's how you get to that result. What it says in the standing order is that any at-risk person who voluntarily requests naloxone, any person who is a friend or a family member of an at-risk person, or any person who is in a position to assist an at-risk person. Certainly anybody who meets those bolded risk factors that we discussed previously would fall under this category. So someone taking 50 MME or higher, someone taking a benzodiazepine with an opioid, or someone who's already had a documented overdose or substance use disorder. The key thing here is that each dispensing of naloxone must be paired with patient education. So it's not enough to just put this drug in their hands, but we also need to talk about how to use it and when to use it with our patients. Lastly, I just wanted to highlight that this is so important. The Surgeon General was talking about it less than a year ago. And they stress the importance with phrases like emphasizing the importance of the overdose reversing drug naloxone. And then they followed that quote by saying, knowing how to use naloxone and keeping it within reach can save a life. And that's really what we're trying to do here. We're trying to save lives. So that's enough for the background story. Let's talk about the approach itself. So what is the standardized approach? And what we've seen is we've actually launched this approach in a pilot pharmacy in North Carolina, and we've shown success with it. So the training materials that you'll see throughout the remainder of this presentation have actually been used already and shown success. And they've been published in an abstract in the Journal of the American Pharmacists Association. And the complete manuscript is actually under review right now. And so I would be remiss if I didn't thank the University of North Carolina Eshelman School of Pharmacy and Kroger for the time that I was allowed to help to implement this service. So what are the goals of our approach? At its core, what we're trying to do first and foremost is train each pharmacy team member to do every step of the process. And what I mean by each team member, I mean everyone who has access to the pharmacy. So I'm talking about the pharmacists, surely, but also the technicians, the students, the clerks, anyone who's working in that pharmacy can become a part of this approach. Secondly, we want to be able to identify the patients who can benefit from having naloxone on hand. And thirdly, we want to be able to implement this approach so that we can offer and dispense naloxone to those patients that we've identified. And now I mentioned team-based before, so why is it important that we do this as a team-based approach? And what does team-based approach mean? Well, first, it works best when the entire team is engaged. Quite frankly, this approach works best when everyone is on the lookout for patients who could benefit from this, and when everyone is working together to make sure that they can implement it successfully. And so it makes sense then to go ahead and train every team member before even trying to implement this. That way you're not retraining or answering questions as frequently throughout the process. Any team member can perform any of the steps in this process except for two of them, and the pharmacist has to do those two steps. And the only two steps that the pharmacist has to do is the confirming that a patient meets the need for naloxone, and this is after someone else has already identified them as a naloxone-eligible patient. And the only other thing that a pharmacist has to do is counseling the patient on naloxone and then offering to sell it. Otherwise, anybody can do any step of this approach. So when we engage our entire team here, the weight of the implementation doesn't rest solely on the pharmacist, and that will make it a lot more successful. So who are naloxone-eligible patients? Well, our patients that are eligible for naloxone, this is going to look very similar to those risk factors that we bolded at the very beginning of the presentation. But it's our patients or the caregivers of our patients that are ages 18 or older, and they have one of the following risk factors. So again, that 50 MME or higher, the morphine milligram equivalents, or they're taking an opioid and a benzodiazepine, or for simplification, a fentanyl patch of 25 micrograms per hour or higher, or they have that verbal or documented history of an overdose or substance use disorder. And while we don't always have this documented history of overdose at the community pharmacy, it is important to include this just because if we had access to that information, we certainly want to offer to dispense naloxone for these patients. So who's not included? This is a little bit less. It's our patients that are not quite 18 years of age yet, or patients who are receiving less than a 5-day supply and have not had any other opioids in the previous 30 days. And the reason for this is just to exclude simple cases of dental extractions or things of that nature, where we're not actually really concerned. Now, certainly if they're receiving less than a 5-day supply and they've received other less than 5-day supplies fairly regularly, then they would meet the criteria still. As long as it's been more than 30 days since their last prescription, that's when they become excluded, if it's less than 5-day supply. So the following are the actual workflow steps for the implementation. Again, all staff members are trained prior to implementing this approach. The morphine milligram equivalence conversion chart and the workflow checklist chart are provided ahead of time, and they are made visible within the pharmacy. So they're either hung up on the walls or they're placed on the counters at the stations. They're somewhat accessible. So when someone receives an opioid prescription, they can simply glance at that chart and say, oh, this is greater than 50 MME. They do meet the criteria. And both of these charts will be displayed later in this presentation, but they will also both be made available on the NCAP website. So it starts with the receiving of an opioid prescription. And so when an opioid prescription is received, whoever that team member is goes ahead and reviews the medical record for naloxone eligibility. If they determine that that patient does meet the eligibility to receive naloxone, then it does need to be confirmed by a pharmacist. That's one of the steps that the pharmacist has to do. If the pharmacist does confirm that the patient meets eligibility, then they would place a hard stop in the dispensing software. And what that means is that they can't dispense that medication without the pharmacist speaking to the patient first. And that way we would actually be able to have this conversation about naloxone. Next, we want to make sure that we're tracking our processes and making sure that they're effective, or in other words, quality assurance. So we're going to use a documentation sheet to record that a patient was identified as naloxone eligible, and we want to include limited demographic information. So things like the gender of the patient, the age of the patient, and then whether or not they met that naloxone eligibility. The next step is the pharmacist goes ahead when the patient comes in to pick up their opioid prescription. The pharmacist educates them on the risks of opioid medications, the benefits of having naloxone on hand, and then makes that offer to dispense naloxone right there at the pickup window. And then regardless of what that patient decides, all patients will be provided with an educational handout from naloxonesaves.org. And this is just to provide additional education for our patients and to assist them in making that decision downstream if they decide not to take that naloxone today. Okay, so I mentioned that we would have these charts later on in the presentation. This is our MME conversion chart. And you can see we have our common opioids down the left side, followed by the conversion factors in the middle. But we took it a step further and we converted what the dose would be for each medication to be equal to 50 milligrams of morphine. So as a hypothetical, if somebody was taking hydromorphone, if they were taking more than 12.5 milligrams a day, then that would be greater than 50 MME, and they would automatically meet the requirements to be eligible for naloxone. It is worth mentioning that these numbers on the right side are just if they're taking one medication. So if they're taking more than one medication, you would want to make sure to add up all of the medications. This next chart is our workflow checklist. And so this gives you a step-by-step detail of what to do when you receive that opioid medication. So you'll see first and foremost, it describes which medications are opioids. And then you follow along, review the patient medication record, calculate MME, alert the pharmacist if they meet the criteria. And then you have a pharmacist box here as well. Verify that they met the criteria, place that hard stop, educate the patient, provide educational handout. So you can see that all of this is really spelled out, and these couple of documents could be placed throughout the pharmacy so that there's never really any question about what should be done next. So I want to share our success story in our pilot pharmacy in North Carolina. We implemented this exact same approach, and what we saw was a significant increase in the number of naloxone sales. By just increasing our attention by a little bit, we saw a marked number of sales of naloxone. We increased the number of life-saving medication by a dramatic amount. And we didn't ask patients to let us know if they needed to use this medication. But we actually had multiple patients come back to our pharmacy and tell us that they did indeed have a need to use their naloxone. And what that equates to is we potentially had lives saved as a result of implementing this approach. And that's really what it's all about. And that was a huge impact not only on our patients, but also on our pharmacy team. So the next steps here are to download these training materials from the NCAP website. Now, I mentioned that those charts are going to be on the NCAP website. This presentation will always also be on the website. So you can watch it on there. You can download this presentation too for a quick reference. After you download the training materials, meet with your pharmacy teams. Train them. Discuss what the procedure will look like at your pharmacy and go over these resources that are available. And then lastly, begin to plan for the implementation of this approach. Think about individually, what does your pharmacy need to get started? Maybe you need inventory. You need to go order the Narcan or the naloxone. You might need to figure out where you're going to hang these charts, these resources. You might want to start printing out some of those educational handouts. Think about what works for you and what you're going to need at your pharmacy. And then lastly, email our project manager. So the manager of this project is Weta Gatton, and her email is wetad@gmail.com. And let Weta know that you've completed this training. That's going to be the next step. And then please ask her any questions that you may still have about the approach after watching this video. And we're happy to answer any questions that you have so that we can make this as seamless as possible. So thank you all so much for your time, and I really look forward to hearing how this goes and answering any questions that you have.